Hey everyone, and welcome back to Breaking Down Nursing, Electrolyte Edition. Before we talk about individual electrolytes, you need to understand the pattern, because electrolytes are not random lab values. Every electrolyte mainly controls one major body system. There's 5 electrolytes we care about the most, and when the electrolyte goes wrong, that system fails first. For example, sodium. Its primary system is the brain and fluid balance. And what happens when it's outside parameters? You can have things like seizures or confusion. Potassium. Its primary focus system is heart rhythms. When we have outside normal limits, lethal arrhythmias. Next is calcium. That controls muscle contraction. Remember, we all had to learn about sliding filament theory and anatomy that we also tried to forget. This is where calcium comes to play the most, along with bones. It can cause tetany or coma. Magnesium helps with neuromuscular stabilization and can cause things like torsades or reflex problems. And then, of course, phosphate, last but definitely not least, plays a primary role in our energy or ATP. Remember back in chemistry with our Krebs cycle, phosphate affects energy or ATP. And if we have too little, can cause respiratory failure. Okay, so let's talk about each one individually. Some causes, treatments, signs and symptoms, and of course, what's our normals? Moving into hypernatremia, that's a sodium level greater than 145. Some causes of a hypernatremia: diabetes insipidus. Now remember, diabetes insipidus has nothing to do with glucose and everything to do with your pituitary and your ability to maintain and regulate fluids. Other causes: dehydration, burns, decreased fluid intake, diarrhea, and of course hypertonics. So when trying to remember some signs and symptoms of hypernatremia, think salty brain. S stands for seizures, agitation, lethargy, thirst, yawning, bounding pulse, reflex increase, ultramental status, irritability, and neurodysfunction. Because remember, our cells shrink and become dehydrated when our sodium levels are too high. So of course, with treating hypernatremia, we want to treat the underlying cause. We either have too much salt on board or not enough fluid. Hypotonic fluids would be a good solution along with free water. But again, always depends on what's causing the situation. And of course, always remember that there are times where we allow for permissive hypernatremia in the world of neurology or neurosurgery to elevate that sodium a little bit to help with cerebral edema. Let's move to hyponatremia, and that's a sodium level less than 135. Some causes: of course, the opposite of DI is SIDH, or syndrome of inappropriate antidiuretic hormone, where we retain too much fluid and we dilute the sodium that we have. Cerebral salt wasting, of course, renal disease, vomiting, diarrhea, adrenal insufficiency, and of course, water intoxication. Some signs and symptoms to remember is brain swelling. Because remember, with hyponatremia, the fluid goes into the cells to dilute it, creating cerebral edema. So we'll have signs and symptoms like behavioral changes, reduced reflexes, anorexia, increased ICP, nausea and vomiting, seizures, weakness, edema, lethargy, and low blood pressure. And when focusing on treatment, of course, we want to treat the cause as well. Some treatment examples: normal saline or hypertonics, or fluid restriction, so that we don't further dilute that sodium level. So next is hyperkalemia, and that's a potassium higher than 5. So remember, most of your potassium is inside of your cells, whereas most of your sodium is in your intravascular fluids. So some causes of a hyperkalemia are things like increased potassium intake or cell disruption, or that then releases the potassium inside the cell into our vascular space, which will cause a sharp increase in our potassium. Include burns, necrosis, anything that would destroy cells themselves. Of course, decreased excretion, acidosis, and addisons. Signs and symptoms to remember hyperkalemia: think murder. M for muscle weakness, U for urine output low, R for respiratory distress, D for decreased cardiac contractility, E for EKG changes like peaked T waves, and R for reflexes decreased. Treatments for hyperkalemia depend on patient stability. If your patient's stable, we may give things like Lasix or KX-Late, and that pulls the excretion of potassium straight out of the body and gets rid of it. If your patient's unstable, having EKG changes, ultramental status, we may give things like insulin D50, albuterol nebs, calcium, and sodium bicarb to buy us time until we can get and fix that potassium level through things like hemodialysis. Now remember, your insulin and D50, your insulin only shifts the potassium into the cells, and D50 is to replace glucose lost by giving the patient insulin. But this is only a band-aid. One thing to look at when your potassium level comes back sharply elevated and there's been no change to the patient is to verify if the sample was hemolyzed. Hemolyzed samples can falsely elevate potassium levels. And if your patient's stable, we may need to ask for a redraw just to verify that that lab is correct and not due to the hemolysis of the cells. So let's move to hypokalemia. This is a potassium less than 3.5. Some causes include decreased intake, GI losses, increased excretion, things like perspiration, and aldosterone excess. When trying to remember the signs and symptoms of hypokalemia, think suction. S for skeletal muscle weakness, U for U waves on EKG, C for constipation, T for T wave depress, I for irregular pulse, O for orthostatic hypotension, and N for numbness. Treatments may include potassium. We have PO route or IV. Just always remember, a max for a peripheral line is 10 MEQs per hour, and for a central line is 20 MEQs per hour. Whenever replacing any of your electrolytes, always remember to monitor your EKG, and potassium is no exception. Potassium should also only go through an IV pump. If you have a syringe full of IV potassium, something's very wrong. Go back, check your orders, and check medication. Potassium replacement should only go through an IV pump. And of course, if you're having a hard time replacing potassium, always recheck your MAG levels. If MAG levels are low, it'll be hard to replace potassium until we have corrected the MAG levels. Next up is hypercalcemia, and these are calcium levels greater than 10.2. Some of the causes include bone release, bone tumors, hyperparathyroidism, vitamin D toxicity, and decreased renal excretion. An easy way to remember our signs and symptoms includes the saying, stones, bones, groans, thrones, and psych overtones. Stone stands for kidney stones. Remember, high levels of calcium increase our risk for kidney stones. Bones for bone pain. Hypercalcemia is incredibly painful, and sometimes we can actually get psychiatric moans from it. Groans from abdominal pain, constipation. Throne means polyuria or dehydration. Psychiatric overtones referring to confusion. How do we treat hypercalcemia? Giving things like calcitonin to push that calcium back into the bones. Furosemide to get rid of it. Biophosphate, increasing fluids to flush it out, and increasing fiber intake to help flush it out through your GI system. Moving on to hypocalcemia, this is calcium less than 8.6. Some causes include hypothyroidism, renal failure, decreased GI absorption, vitamin D deficiency, pancreatitis, and hyperphosphatemia. Because remember, at the end of the day, phosphate and calcium are indirectly related. So if phosphate's up, calcium will be down, and vice versa. If calcium is up, phosphate will be down. Always remember signs and symptoms. Think of cats. C for convulsions, A for arrhythmia, T for tetany, and S for stridor spasms. We have two treatment options. Oral calcium. We can give calcium chloride. So remember, 1 gram of calcium chloride is 13.9 MEQs of elemental calcium. It's generally why we leave it for patients who are in cardiac arrest, because there's such a large amount of calcium inside of it. Versus our calcium gluconate has 4.65 MEQs of elemental calcium. And that's usually our drug of choice when replacing calcium in the hospital setting. As a side note, ionized calcium remains normal in low albumin states, and you may see this for your patients with ascites or liver failure. Renal docs may go off of ionized calcium instead of just a calcium level in general when figuring out if the patient needs replacement or not. Moving on to hyperphosphatemia. This is a phosphorus greater than 4.5. Some causes include decreased parathyroid hormone due to calcium alterations, decreased output like renal failure, acidosis, crush injury. Just like earlier, when we release potassium, we also release phosphorus into our body. And of course, tumor lysis syndrome for patients that are undergoing chemotherapy. Our signs and symptom mnemonic for hyperphosphatemia is phosphate. P stands for paresthesia, H for hyperreflexia, O for overactive muscle like tetany, S for seizures, F for facial twitching, A for arrhythmias like prolonged QT intervals, T for Trousseau sign, and E for excitable neurons. Treatment for high phosphate include things like phosbinder drugs, and of course the diet low in phosphorus. Moving on to hypophosphatemia, and this is a phosphorus less than 3. Some causes include increased GI and renal losses, decreased intake, alcoholism, increased movement into the cells, increased parathyroid hormone, or PTH. Our signs and symptoms, think low power. P for poor muscle strength, O for oxygen delivery decrease, W for weakness, E for encephalopathy or confusion, and R for respiratory failure. Remember, phosphate's needed to make ATP, so if we don't have enough phosphorus, we don't have energy. So some treatments include K-phos or sodium phos. Depending on which one really depends on what our potassium and sodium levels are. When giving IV phosphate replacement, we need to infuse over 4 to 6 hours. So this is a slow infusion. We don't want to do it too quickly. And of course, we can give oral phosphate. Just remember, this may cause diarrhea. Moving on to hypermagnesia. This is a MAG level greater than 2.5. Some causes include increased intake like TPN, decreased output such as renal failure, and of course some malignant tumors. Signs and symptoms for hypermagnesium, think lethargic. L for lethargy. E for EKG changes. T for tendon reflex decrease. H for hypotension. A for arrhythmias. R for respiratory depression. G for GI upset. I for inactive bowel. And C for cardiac arrest. Treatment includes stopping the mag infusion if there's a mag infusion running, administering furosemide to get rid of the extra magnesium, and calcium gluconate to help stabilize the heart. Moving on to hypomagnesia. This is a mag level less than 1.5. Some causes include malnutrition, alcoholism, diarrhea, diuretics, hyperaldosteronism, and hyperparathyroidism. Signs and symptoms to remember: think twitching. T for trousseaux. W for weak respirations. I for irritability. T for torsades de pointes. C for cramps. H for hyperreflexia. I for insomnia. N for nausea. And G for glasses, meaning nystagmus. Treatment includes monitoring EKGs with any infusion given, and we administer magnesium sulfate IV, generally 2 grams, or PO magnesium. And that's it for this one. If this helped things finally make sense, hit the subscribe button at the bottom. As always, thanks for watching, and I'll see you next time.